Okay, thank you for joining us today on understanding the prior authorization process for repetitive scheduled non-emergent ambulance transports, otherwise known as RSNAT. My name is Mary Sue Gardner, and I'm a registered nurse on Provider Outreach and Education, and I'm going to be your facilitator for today's event. I'm also joined by Jennifer from Provider Outreach and Education, and as well as representatives from Medical Review who are going to be assisting in the Q&A portion of today's event. A few housekeeping issues to let you guys know about. We have a training center webpage on WPSGHA.com. Under that training center webpage, you're going to find all things training, like the presentation for today's event is located in the training material. You're going to find upcoming events. You're also going to find encore presentations, which are the recording of our live events. And those are actually available on our webpage for about 60 to 90 days, but always available on our YouTube page until that information is either updated or changed. If you have any questions for today's event, please place those questions into the chat feature for today's event. So that same place that you see Jennifer posting all the additional information, go ahead and place your questions in that. And then finally, Jennifer is going to place in that chat for you a copy of our survey for today's event. We welcome your feedback, and we want your feedback on our event and how we did today. And that information goes directly to CMS. So Jennifer did place a copy of it in our chat right now, and she'll place it again in the chat again later. But if you find you have to leave before the formal presentation's over, go ahead and utilize that link she gave you and take our survey. On your screen right now is our disclaimer. We have to give our disclaimer in all of our live events. And this disclaimer basically says the information we're giving you today is a tool to assist you, our provider community, in the Medicare laws, rules, and regulations surrounding RSNAT services. However, if the laws, rules, and regulations happen to change tomorrow, it's your responsibility as a provider to make sure you are following the laws, rules, and regulations as they are on the day of coverage you are providing that service to a Medicare beneficiary. We also ask that you do not audio or video tape this presentation for any profit-making purposes. However, we are doing that for you, so there is really no need to do that, and it will be posted to our YouTube page probably by tomorrow and available on our Encore page within the next week or so. Acronyms. Now, Medicare's full of acronyms, and so is RSNAT services, hence the acronym RSNAT. If I happen to use an acronym today during the course of this presentation and you don't know what it means, you can just refer back to this list. If it's not on this list and I happen to use an acronym, go ahead and place it into the chat and someone will assist you with what the meaning of that actually is. And then additional acronyms as well listed here. All right. So our objective and agenda for today. What do I want you to get out of today? I want you to gain a better understanding of the prior authorization process for repetitive scheduled non-emergent ambulance transport. And we're going to accomplish that today by going over an overview of the prior authorization process, who it pertains to, which leads us into the coverage criteria, what you have to have in order to request a prior authorization. And then we're going to talk about some of the common review findings that perhaps make a request for prior authorization for this service not not affirmed on the first request, because we want you to actually avoid those things. So moving on, let's give a little bit background about the RSNAT process. So prior authorization. Now, CMS runs a variety of programs that support efforts to safeguard beneficiary access to medically necessary items and services. And this is done while reducing improper Medicare billing and payment. So through the prior authorization and pre-claim review initiative, CMS actually helps ensure compliance with Medicare rules. So under the prior authorization, providers or suppliers, you actually submit prior authorization requests and you receive a decision about those requests before those services are even rendered. A provider or supplier submits the prior authorization request and all supporting medical documentation. And you do that in order to receive a provisional affirmation of coverage for the services to your Medicare administrative contractor. We at WPS are, hopefully everyone listening, Medicare administrative contractor. So as the MAC, we take that information and we review those requests and we send you, the provider or supplier, an affirmed or a non-affirmed decision based on what we receive. The purpose of the prior authorization process is to help ambulance suppliers ensure that their services comply with all applicable Medicare coverage and coding and payment rules before you actually provide the services and before you submit a claim for payment. So this prior authorization model or process, if you will, it applies to independent ambulance suppliers that are not institutionally based, that are providing Medicare Part B covered ambulance services, billed on a CMS 1500 form or the electronic transaction equivalent, the 837P. So we're going to talk a little bit more about the model inclusions here in a little bit. Things to note about this RSNAT process. So prior authorization, the process itself does not create any new clinical documentation requirements. Instead, it requires the same information that is already required for you to have to support Medicare payment just earlier in the process. So we're going to go through those documentation requirements in a little bit here. But prior authorizations allow providers and suppliers to address any issues with claims prior to rendering the service and prior to submitting that claim for payment, which has the potential to actually reduce appeals for claims that may otherwise be denied. Prior authorization for RSNAT, it's also a voluntary process. And as we move on to this next slide, we're going to talk about that voluntary process in a bit. All right. So as I mentioned on the last slide, this process is voluntary. However, if an ambulance supplier elects to bypass the prior authorization, applicable RSNAT claims could and will be subject to payment, to prepayment medical review. So let's talk about when that could happen. So claims for the first 3 round trips, or that would be 6 one-way trips, those are permitted to be billed without prior authorization and without being subject to pre-pay medical review. After the third round trip, your claims can be halted from processing to the payment floor, and we can actually request review of payment of those services. So repetitive, scheduled, non-emergent ambulance transports. Again, if you decide not to participate in the prior authorization process, only 3 round trips will be able to go through without halting before they go to the Medicare payment floor and requesting that you submit documentation for review. So let's move on and discuss a little bit more about the coverage for this model. And I apologize, my computer is just got a mind of its own. I give it one click to advance the slide and it takes 2 automatically. Okay, for any service to be covered by Medicare, there are certain things that have to exist. So there must be a benefit category, and that patient must be eligible for services under that benefit category. Also, services have to be reasonable and necessary for the diagnosis or treatment of an injury or to improve the functioning of a malformed body member. And finally, C, or the third thing for Medicare coverage, is you have to meet all other applicable Medicare statutory and regulatory requirements. Now, the medical necessity requirement for Medicare coverage for ambulance services, those things are actually set forth in the CFR, and that's the 42 CFR 410.40, which is listed here on the slide. If you have the slide deck in front of you, you can actually click on that, and it's going to take you to the Code of Federal Regulations, and it's going to take you right to 410.40. All right, Medicare covers ambulance services, and that also includes air ambulance, which isn't included in the RSNAT, but just so you know. So fixed wing and rotary wing, when it's furnished to a beneficiary whose medical condition is such that other means of transportation are contraindicated. So that's the important thing to remember for medical necessity for all ambulance transports. It is considered medically necessary when all other means of transportation are contraindicated. So the beneficiary's condition must require both the ambulance transport itself and the level of service provided in order for the billed service to be considered medically necessary. So in addition to meeting medical necessity requirements, the services, again, must meet all other Medicare coverage and payment requirements. And again, this includes requirements related to origin and destination of the transportation, vehicle and staff, and even your billing and reporting. So I've given additional references here where you can find additional information and coverage criteria on the ambulance services. So let's talk about the coverage on the non-emergent transports. Non-emergent transports by ambulance is appropriate if either the beneficiary is bed confined and it's documented that the beneficiary's condition is such that other method of transportation are contraindicated, or the beneficiary's medical condition, regardless of the bed confinement, is such that transportation by other means would be contraindicated. So again, regardless of it, if they need it for a medical purpose because of, you know, the patient's state of well-being or non-well-being, then that could also meet the requirements for the non-emergent transport. So let's break this down and talk about the bed confinement right here. Okay. So under Medicare the Medicare guidelines, for a beneficiary to be considered bed confined, the following criteria must be met. So the beneficiary is unable to get up from bed without assistance, and the beneficiary is unable to ambulate, as well as the beneficiary is unable to sit in a chair or wheelchair. So when we are looking for documentation to support bed confinement, which doesn't mean, you know, the patient is bed bound, but bed confined, we are looking at your documentation needs to let us know why they are unable to get out of bed without assistance, why they are unable to ambulate, or the fact that they are unable to ambulate, and that they are also not able to sit in a chair or wheelchair, because someone may be bed bound but can sit safely in a chair or wheelchair, which would mean that perhaps in their instance, transport by an ambulance would not be medically necessary, that they could go by a wheelchair van. So let's talk for a little bit on repetitive ambulance services and what those are. They are medically necessary services. So medical necessity in an ambulance service really means Medicare will cover the ambulance service only if they're furnished to a beneficiary whose medical condition is such that other means are contraindicated. So the beneficiary's condition must require both the ambulance transportation itself and the level of service provided in order for those services that are being billed to be considered medically reasonable and necessary. So do they need that level of EMT? Do they need that level of transport? Now, for the repetitive services, the other things that exist besides medical necessity is furnished in 3 or more round trips. Again, remember that 6 one-way trips during a 10-day period, or at least 1 round trip per week for at least 3 weeks. These transfer types are typical for beneficiaries that are receiving things like dialysis treatments or cancer treatments that also meet the medically necessary requirements, you know, and or bed. All right, so Medicare, again, covers RSNAT services when the coverage criteria indications are met. Again, that includes meeting that medical necessity requirement, as well as making sure that you, as an ambulance supplier, has also obtained a written order from that person's attending physician certifying the medical necessity of that repetitive scheduled non-emergent ambulance transport. So we're going to move on and talk about all of this as well. All right, so some of the inclusions for the RSNAT model. Again, I went over this at the beginning, but I want to stress this. This model or process, as you will, this is not for all ambulance suppliers. If you are institutionally based and you bill on a Part A type of claim to Medicare, this is not for you. This is only for those independent ambulance suppliers that are billing on that 1500 or the 837 electronic equivalent. They are not institutionally based, so they're, again, billing Part B services. You are not under current review by somebody else, and you are not, again, hospital-based, like owned or operated by like a critical access hospital or skilled nursing facility or a comprehensive outpatient rehab facility, or even a home health or hospice entity. So there's some specific, criteria of who's included in this model. And I just like to make that clear because these webinars are open to everyone, but this model itself doesn't apply to everyone that provides hospital or repetitive scheduled non-emergent ambulance transports. All right, so what codes are subject to the repetitive scheduled non-emergent ambulance transports? The codes included in this model are the A0426, and that's for the ALS transport, and the A0428 for the BLS transport, a basic life support transport. It doesn't include mileage codes, because remember, you won't have that mileage prior. So you are receiving a provisional affirmation on the transport codes and the medical necessity of that upcoming transport at that level of service. So again, your documentation is going to need to support that the person is medically necessary for the ambulance transport, and then depending on which code type you are billing, why does it need an ALS level of care or a BLS level of care? So those are the other things that you need to, support within your documentation. All right, so let's move on and talk about submitting those requests and the documentation requirements associated. Submitting a request. So on this slide is the basic information about submitting your prior authorization request. You have several options. You can download and complete a hard copy prior authorization request form and send the documentation as well as the form in via mail or even fax or even ESMD. Or the preferred way and the easiest way for you to do it is submit that information through our secure portal. We're going to link out to the WPS website, and I'm going to show you the form as well as where you can find the information. And if my computer's going to play nice, which it is lagging a little bit, we've all seen that happening. Give me just a second here. And I am going to just open up a tab, and I went to WPSGHA.com. All right, so since this is a Part B service, you want to make sure you choose your correct part as well as your correct jurisdiction. In this case, I'm going to choose J5 Max Part B. And again, excuse my slowness of my computer here. All right, so once I'm out here, I'm going to go under Tools, and I'm going to look at all tools. And there are several different ways to get to various different things. I'm going to hit Accept. That's just the licensure agreement that every website has. And I'm going to go over here to All Forms. I'm going to scroll down here, and I'm trying to scroll a little slower to Prior Authorization. And I am going to click right here on Prior Authorization Request, and this is for RSNAT, fax or mail, cover sheet, and you can see this is specific to J5B. That's why I said it's important that you're choosing the correct jurisdiction as well as the correct part, because different jurisdictions are going to have different mailing addresses. We're going to click on that, It's going to give you additional information about completing this. I am going to click on download, and you're going to see it's going to open this prior authorization request form. Now, if you complete the information in the secure portal, the information is going to automatically populate for you, and I'll show you that here in just a second as well. So again, remembering this one is specific for Part B, J5, make sure you are choosing the correct one. Then you're just going to complete this request in its entirety. Is this the initial? Is this the resubmission? Number of transports. Remember, round trips are 2 transports. So you are listing the number of transports in single or one-way trips. You're going to give us the information on the start of your 60-day period. You're going to give us the procedure codes. So is it the ALS or the BLS? Is it, the A0426 or the A0428? Any applicable modifiers that go along with that, you should give us those as well. You're going to give us the information about you as the ambulance supplier. That includes the state where your ambulance is actually garaged. We need to know that information so we can verify if your request is going to the correct map. And that happens every once in a while. We have someone that's in our jurisdiction, but their actual ambulance is not. And so in those cases, we want to make sure you're going to the correct map. Then you're going to give us all the beneficiary information, first, last name, their MBI or Medicare Beneficiary Identifier, and date of birth, and then all the information about the certifying physician. And we need to have all this information. So you are going to have to contact their office and get their MPI and PTAN number. And then your contact information. Who do we contact in case we have questions? Who do we send the information or the affirmation back to? And then here is information if you're going to fax it, if you're going to mail it, or if it's going to come via a delivery service, where it's going to go. All right, I'm just going to back out of this. I'm going to just click on the WPS, so it's going to take me to the home page, and I'm going to click on the portal user manual. So this is the user manual for our SNAP system, so the Secure Net Access Portal. So if you scroll down and you go to prior authorization, you're going to find information about prior authorization. And here you can see the information for prior authorization of RSNAT services. So that linked you back to some additional information on RSNAT itself. So as I scroll down into this, it's going to show you what the screens actually look like when you are submitting your prior authorization request in SNAP. So again, where under the transactions, you're going to select on prior authorization, and then as we scroll down, it's going to give you the RSNAT specific information as well, which I started scrolling. Oh, nope, I was hoping I didn't pass it. So again, same things. The prior authorization, here's the preliminary information. Here's where you fill in your supplier, beneficiary, requester, certifying physician, etc. Obviously, I can't take you out into the secure net access portal because it is secure. We don't want to show you any beneficiary information that contains live claims, so we can't open it up and show you because then we would be giving out PHI and PII. But if you have any questions, that information in the manual will walk you through exactly what those screens look like. So as I jump back to the slide deck, I'm going to move on. and talk about that PSC or physician's PCS, physician certification statement. Remember, a condition of coverage for RSNAT transports is that the patient must be under the care of a physician, and that physician must order and certify the need for those RSNAT services. So why does the physician feel that your patient or your beneficiary must be transported by ambulance? Why is it the only safe means of transport for this patient on these days? So basically, they're supporting the medical necessity. There isn't a specific form. However, we made a sample PCS form, and that's available on our website. So I'm going to jump back into our website and show you that form just really quick. And if you are on the Part B, you can actually just search physician certification statement. I'm a searcher, not a navigator. I like to get to things quick, but you can just do a basic search and it will, the option will come up. So if we download this, I want you to be aware of this, and you don't have to use this form. We created it, again, as an example to help our providers. But if you have your physicians complete a form or make sure they have all the information that, we have tried to guide you to show us the medical necessity, if they go through this, this is really going to help you in supporting the medical necessity through that physician certification. They are actually giving the indications of medical necessity. Why does this person need that level of transport, be it ALS or BLS? Why is transport by ambulance the only safe means for this person? Are they paralyzed and they cannot sit or hold themselves in place? Do they have severe contractures? Is there some special handling, like there are certain anatomical positions due to the nature of this patient's illness or accident or injury that they need to be in that they couldn't safely sit? Are they exhibiting signs of decreased level of conscious that make it difficult for them to transport by any other means? Does the EMT have to monitor for something? What kind of interventions does the EMT need to provide during transport, whether that's medications or medical interventions? What are those? What needs to be done? Are they ventilator dependent? So what kind of ventilator settings need to go, with this patient when they're on a mobile ventilator? Is there suctioning that needs to happen, et cetera? You can look through this and read this. Again, you're not obligated to use it, but we created it as a nicety for you, and we really hope that you at least take a look at it and recreate something that is similar if you don't want to use this, and make sure your physicians are filling this out in its entirety to the best of their abilities. And that's really going to go a long way in supporting medical necessity. So remember, just because the physician says that transportation by ambulance must be done, it doesn't make it fully medically necessary. We need that documentation, such as filling out all the information in here at the time of the transports, that really support that this transport is for Fred today, meaning all other means of transport on that day for that beneficiary are contraindicated. So let's jump back into the PowerPoint and move on, and just go over quickly some of the documentation that needs to be included. So we've talked a lot about the physician certification statement or order for services, and it can't be dated more than 60 days before that transport is to occur. So any other documentation from your medical records or for the physician's office medical records that is going to support medical necessity, you know, and support that other means would be contraindicated, just submit that. Any information on the origin and destination of the patient. So where are they being picked up and where are they going to, as well as the return origin destinations for this transport or for these transports. And then again, any other relevant documentation that you deem necessary, like if you have medication administration records because there are medications that need to be administered en route or ventilator settings or things like that. Those, again, are huge in supporting medical necessity and showing that other means of transportation would be contraindicated. And then again, we went over this a little, but I want to touch base on it again, is how do you submit it? The portal is the preferred way. So your electronic could be the portal or ESMD. You can submit via postal mail. Again, you would use that form we talked about for your jurisdiction, and you would make sure you are submitting it to the address that's listed on there. So again, it goes a long way to support the importance of following the jurisdiction, following the part, making sure you have the correct addresses. You can also submit via secure fax, or you can submit a CD or a DVD or a flash drive. Now, those have to be encrypted. If you're going to do those, there is information on our website as well, under the RSNAT services, about the fact that you have to make them password protected. You have to email us in advance that password and the tracking number for the CD or DVD or flash drive that you are setting. Okay, sending. All right, and then we're going to follow up just a little bit about the review process. And everything I've talked about prior to this kind of leads up to the review process and the things that we need to have to make that review decision. So after we receive the medical records and the request form, we as a MAC are going to review that information and postmark our decision. So starting this year, after January 9th of 2025, our time frame went to 7 calendar days that we have to review the request and make a decision. Things that also went away after the beginning of this year also included an expedited determination, because there should be no reason for an expedited determination for a service that is non-emergent and it's repetitive and it's scheduled. So that used to be part of the process, but it no longer exists because it really wasn't relevant. Now, when we make a decision, a few things can happen. We can give a provisional affirmed decision, which means that we agree and you are good to provide the services and bill them to Medicare. We could non-affirm your decision, or we could partially non-affirm. We could affirm some of it, but not affirm other parts. Which you can then resubmit a request if we non-affirm a decision or partially non-affirm with additional information that if you feel it supports medical necessity. Or else we could flat out reject that review request. And a rejection is going to be one of those things that it's not supposed to go to us. We're just not affirming it. It is not the right type of request or something like that. All right, so breaking down these, again, just a little more, I've kind of already talked about them. Again, it's a provisional affirmation. It's a preliminary finding for a future claim. It's saying in the future, when you provide this within those timeframes we discussed, most likely you have everything that's going to meet coverage and coding and payment. If we non-affirm it, it just means we didn't have everything, or we don't agree that transport by any other means is contraindicated. And if we reject it, we're just unable to process the request due to it just not being complete, or it's invalid, or maybe it wasn't even supposed to go to us as a match. A little bit more about the provisional affirmation. When we affirm it, we're also going to send you a decision letter that contains a unique tracking number. That unique tracking number will be what you need to put on your actual bill to Medicare. So make sure you don't lose that unique tracking number. Physicians' offices don't need that, so you don't need to supply that to the certifying physician. It's only for you as the ambulance supplier. And we're going to send that back to you in the means in which you sent your request. Again, if you send your request via the portal, your decision's going to be in the portal as well. So a decision letter is also going to be mailed to the beneficiary, so the beneficiary knows, what to expect as well about your request. Once you get a provisional affirmation, go ahead and render your service, but make sure you maintain all your records and make sure you submit that with the UTN. Just because we gave you a provisional affirmation doesn't mean you couldn't potentially hit some sort of other edit and, through the claims processing and documentation be halted in the medical review or in the processing to the payment floor for some other type of edit. Non-affirmed decisions, we're still going to give you a letter and unique tracking number. Again, we're going to send that to you in the same way. The decision letter is also going to be mailed to the beneficiary, but these aren't appealable because it's not a medical necessity decision because we haven't billed it yet. This is just a prior authorization request. So again, you can't appeal it. What do? You just gather more documentation and keep resubmitting the request. A lot of time requests are non-affirmed because we didn't have everything that we needed. A lot of times physician certification statements are missing or lacking information that we need, and so we really can't affirm the decision. So the UTN is going to follow you. Basically, that UTN you're going to re-report it when you resubmit a supplemental request. And so again, that UTN follows. If you provide the service and submit the claim and you have a non-affirmed UTN, so we did not affirm the decision, your claim's going to automatically deny. All right, so resubmitting, again, that prior authorization request or that subsequent request, if you had an error or omission in something, we're going to identify, we're going to tell you exactly what did not make the request, affirmed. So if it's missing documentation, you're going to submit that with your prior authorization request. You can continue to provide medically necessary transports during the time that you are trying to get your prior authorization request submitted. So remember, you have up to 3 transports in there if you reach the time frame. But again, make sure you include that original unique tracking number with that request. And then again, information about rejected, and why. We're going to tell you exactly why it's rejected too. Rejected usually happens for reasons other than not supporting medical necessity. All right. And then I know we're right at call end time, but if you have a few minutes and you can stick with me for a few minutes, it would be great. If you have to jump off because of time frames, we definitely understand, and I encourage you to go ahead and use that survey link and give us your feedback on if this information is valuable. But I just want to talk about a few extra things about the review process and what we can do for you. We can affirm up to 40 round trips or 80 one-way trips per your request in a 60-day period of time. So your request can't exceed 40 round trips or 80 one-way trips in a 60-day period of time. If you're going to have to break those up into subsequent requests. The number requested and authorizations, again, are measured in one-way trips, and I showed you how to report that when we looked at those request forms. All right, some special considerations for those patients of yours that have chronic medical conditions. So as a MAC, we can consider extended affirmation periods for beneficiaries that have chronic conditions. And those are beneficiaries that we know are not likely to improve over time. And you've supported that in your medical record, in your documentation. And that established condition is unchanged through 2 previous prior authorization requests for this patient. So 2 prior, 60-day blocks of time that had, up to 80 requests in it. So we could actually grant, if we see this on your 3rd request for the beneficiary, we could actually grant up to 120 round trips, or that would be 240 one-way trips in a 180-day period. So we have a discretion to do that as a MAC for you. And then again, just a little more information on the unique tracking number before we end this discussion. That unique tracking number that you receive is valid for the affirmed time period. So generally 60 days. Unless as a MAC, we grant it for longer because of a special consideration for a chronic condition. So when you're reaching the end of your 60-day period and you have transports that are going to continue to be needed, you are going to have to submit for a new prior authorization request. And then we will, review your documentation, review your information. You still have to support medical necessity, and then we can grant you for another 60-day period of time or longer, again, if you meet those exceptions. All right, and then finally, some common findings. So I'm going to go through these fast. Physician certification doesn't list the reason for bed confinement. The physician certification issues are the most common reason that we don't affirm on the initial request. So physician certification doesn't identify what kind of medical interventions or monitoring or services that require the EMT or that level of care. We also have seen documentation that doesn't support that even a physician certification statement was made or obtained, so we just don't get it. And then physician certification statements submitted without any other supporting documentation. So we get a statement, but that's it. We don't have other supporting documentation from the physician or from the nursing home or wherever the case may be that really supports why this person needs this type of transport. All right, signatures that are missing, dates of service that are missing, dates that are outside that 60 days and not valid to be requested, and even the physician certification statement that's signed by someone other than the physician. So remember, in the cases of repetitive scheduled non-emergent ambulance transports, those physician certification statements need to be signed by the physician. And then resources. And before we move on to the last 2 slides, I just wanted to note a question that The questioner said, we have been having issues with denials on patients that have an affirmed UTN for dialysis, which is a J modifier. They may then have to have an unrelated single date of service round trip transport for an IV infusion at the local hospital, which is obviously an H modifier. Is there some sort of edit that should be catching that if the transport is not associated with an active affirmed UTN? So the one-time transport would not then be a repetitive scheduled non-emergent transport, but it would be a non-emergent transport within those dates of service. I'm just trying to think through everything out loud. Your modifiers are going to be different. You shouldn't be putting a UTN on that claim. I'm not sure if you are, but since that is a one-time non-emergent transport that would not be considered repetitive, it shouldn't have the affirmed UTN. And maybe that's why you're getting denials, because if you are putting that UTN on the claim, the UTN in that case would not be necessary. So if there's additional information, Catherine, about that, you can throw that into the chat as well. But that might be the case. So ask, if you're not the biller, ask the billers if they are by any chance throwing that UTN on there, which in this case it would not require it. All right. So we went through a lot of information, and I appreciate you giving me the extra time to go through a little bit more and to give the rest of the story. But what did we get today? We gained a better understanding of this prior authorization process for repetitive scheduled non-emergent ambulance transports. We achieved this today by going through an overview of the process, the reasoning this process was put into place, the coverage criteria, and even some in the common review findings. And then I just see that Catherine followed up and said, no, the UTN is being put on the claim for the H modifier, but the denial is stating that there is an active UTN for the patient, which is correct, but not for the H, for a J. Okay. You know what, Catherine, I'm going to look into this, and I am going to follow up with you if there's, you know, just so I can get the rest of the story and a little bit more information from you. And once I figure out the answer, you know, and the proper billing, and make sure that this doesn't become an issue, I'll put something out to everyone to let you know what the resolution of this was. So thank you, Catherine, for putting that out, and I will follow up with you. Okay. So again, just a few closing remarks, because I know that we are at the end of time. And again, I appreciate you giving me the time and you know, the importance of going through and learning this information and making sure you're doing things correctly. So giving me a little bit extra of your time today. On your screen, you're going to get an email. It's probably already in your inbox. And this email is actually your certificate of achievement as well. So don't delete this without reading it. It's going to give you an option to go to our survey. But it's also, if you read through and go to the bottom, it gives you contact hours, which can be submitted to NAC for continuing education if you happen to need those. If you have any follow-up questions, go ahead and send those to us at this email address. Jennifer put it in the email, or put it in the chat earlier, but it's also on your slide deck. send us an email. Just put RSNAT in the subject line and send those within the next week. So we can take questions regarding this event for a week's period of time. So you want to get it to us by noon in the next 7 days, and we'll send that out to you. And if it's something I feel needs to go to everyone, I will send out an additional email to everyone that listened, because if it's a good question by one, it might be a good question for everyone to learn. All right. On your screen is a slide that we just want you to know how important taking the survey is to us. We're committed to making changes. Through your survey comments, we want to let you know about some improvements to our educational experience that we've made for you. So we have added chapters to our YouTube. So once this goes to Encore on our YouTube page, you're going to be able to go through and just re-review the sections that you want to review if you want to do that. So it's called chapters in YouTube, and you're going to be able to click through and listen to just specific parts. We've also included training indicators in all our education. So there'll be a training indicator in the description to let you know if this is a clinical event or a billing event or a documentation event, etc. And then finally, I wanted everyone that's on to know we do have a Medicare Education Expo coming up. We're going to be talking about local coverage determinations. So the whole day of webinars is focused on local coverage determinations. And there's different components through the local coverage determination. And we're even having a session where one of our contractor medical directors is getting on and talking about the developing process. So something that may be of interest to you. And then again, finally, the survey is in the chat. We do encourage you to go through, give us your feedback on the event, or when the event closes, you're going to be redirected to a site. It's going to pop up and look like this with this yellow triangle. And it's just WebEx's way of saying we've redirected you to a site. It's not spam. It's going to take you to the survey. So on behalf of Jennifer and myself and all of Medical Review, we want to thank you for your participation in today's event and for giving us the extra time out of your day today. This concludes our webinar, and you may now disconnect.